Yeah. So the WHO smoking fact sheet of 2020 tells you numbers which are actually quite startling. The fact that tobacco, and this is all of tobacco, we're not just talking about smoking here, we are talking about tobacco in all its forms, kills up to half of its users. Now, why that sounds very startling, you need to take into account the organ damage or the multiple organs that might potentially get affected from tobacco in any of its forms, including smoking. The fact that it kills 8 million people each year. So you're looking at two different facets here. You're talking about killing half of its users at any point of time in life, where other comorbidities, organ damage related to smoking or otherwise are also related. But in hard numbers, just smoking related deaths are 8 million people each year, which is more than the number of deaths you have from asthma and COPD in any given year. So these are huge numbers. 80% of the world's 1.3 billion tobacco users, 1.3 billion tobacco users, 80% of them live in low and middle income countries. Hence, it's our problem. It's your problem. It's our problem, which is why discussing smoking, tobacco use, and cessation policies are far more important in an Indian population. When you talk about the burden of smoking, and this again is from the WHO fact sheet, dates back about 12 years, but all of this is still very relevant. We have said that smoking and then smoking cessation is the single most preventable cause of death in the world. We have said that it kills half of its all-time users throughout life, and it's a risk factor for 6 of the 8 leading causes of death. So if you look at the 10 common causes of death from various causes, including heart disease, including COPD, diarrhea, etc., out of the top 8, 6 causes are related to smoking, and the top ones are there in the slide in front of you: heart disease, pulmonary disease, strokes and cerebrovascular disease, and cancers, not just of the lung, but of various parts of the body. And I'll show you a figure in a moment to illustrate that point. Now, when you ask your patients or when you ask your peers, friends, do you smoke? This is the question which is very, very difficult to define. I've had patients coming and telling me that I would have smoked 5 cigarettes in my life. I've had people who come and tell me that I would smoke hookah maybe once every fortnight. And then there are your hardened smokers who smoke 100 a day. Between these two extremes, so smoking 5 in your lifetime and smoking 100 a day, there's a variety of smokers as far as smoking frequency is concerned. And I've put some questions or some statements in front of you there, which illustrates the various forms of smokers. I smoke daily, I smoke occasionally, not every day. I smoke daily, but do not smoke now. So all of these are things which don't give you hard numbers as to how people smoke, nor does it allow you to grade the frequency and the severity of smoking like you would do in maybe someone with COPD. When you say someone has got mild, moderate, and severe COPD, how do you grade the level of smoking? So this is a classification of smokers from a BMC publication by Atkinson, and it talks about the light, medium, heavy, and very heavy smokers. And I want you to quote this for the exams, but also in your day-to-day practice. If you remember this, you have a unified definition in classifying smokers. So a light smoker is, or an ex-light smoker, and you will see the same pattern in all of these. It's either a light smoker or an ex-light smoker. So tobacco consumption less than 10 and greater than 0. That's the first parameter. How many do you smoke? And the second parameter is how quickly after waking up do you light up your first cigarette. So light smoker is 0 to 10 and smoking the first cigarette 60 minutes after waking up. Medium smoker is 0 to 20 and lighting up within 30 minutes of waking up. Heavy smoker is 0 to 40 and lighting up within 5 minutes. and very heavy smoker is more than 40 and lighting up at less than 5 minutes. So remember these 2 points. When you're writing your prescription, writing your answer sheets, remember 2 things. How many do you smoke? And when do you light your first cigarette up after you wake up in the morning? Why do we talk about smoking? There's other such substances which are banned throughout the world, where you could actually go to prison for using these in public, are thought to be far more addictive. So your cannabis, your cocaine, your psychedelics, heroin are all banned throughout the world. However, if you look at addiction potential, nicotine or tobacco scores head over any of these substances. I want you to look at this graph. I hope you can see my cursor. You can see the dependence goes up till the age of about 30. So 25 to 34 is the mean, and then it plateaus off. It never comes down, it plateaus off. With other substances, including alcohol, cannabis, cocaine, etc., see the numbers down below. A, the dependence is lesser. B, you can see a gradual downward drift with aging. So understand that substances which are banned in most countries in the world, the cannabis, the cocaine, psychedelics, heroin, you have a drug which causes dependence far greater and at a sustained level, which is openly sold throughout the world. And this has got more to do with the socio-economical development of countries rather than anything else. And that's something which is important to remember. So why is it so difficult to quit? You must have seen lots of people whom you've asked to quit. I suspect some of you would be smokers in this audience today, and you would have tried to quit. So first question, why do you need to quit? And second question, how do you go about quitting? So why is it important to quit? We've said that the 3 systems which are the most important are the lung. So lung cancer risk increases by 20 to 30%. Heart disease risk goes up by 25 to 30%. And stroke risk is increased by 20 to 30%. Secondhand smoke exposure causes 8,000 deaths from stroke annually. So that's just from stroke. You remember, whenever you talk about smoking, the first 2 things that come to your brain is, one is lung, the second is heart. However, strokes cause 8,000 deaths annually. 700 million children, that's half the children of the world, are regularly exposed to secondhand smoke. So that's the amount of damage we do to our children, your children, who are exposed to passive smoking throughout the world. And why is that relevant to kids? So children exposed to secondhand smoke, mom smoking, dad smoking in front of the mother, increased risk of sudden infant death syndrome. Shambhu spoke about asthma and respiratory disease. So that's something we now understand, that in utero exposure to cigarette smoke, exposure to cigarette, that you need to have asthma at an early age, and ear infections. Sudden infant death syndrome, asthma and respiratory disease, and ear infections are the various factors which affect children with smoke. So the health conceit slide, which is macular degeneration, there's congenital defects due to maternal smoking like orofacial clefts and periodontitis, there's diabetes, there's atherosclerotic peripheral vascular disease, hip fracture, acute myeloid leukemia, you name it, you see the list on here. No wonder we talk about 50% of people who smoke having a causal link to smoking and their mortality. So the reason is there in front of this cartoon, in front of you with this cartoon, which shows you the various organ systems and the various diseases which are causally related to smoking. This is again a great slide. It's a great slide for your exam. It's a great slide to persuade your patients to stop smoking. So the bottom line of this slide is that there is a loss of a decade of life expectancy from smoking between 25 to 60. So smoking between 25 to 60 entails a decade in the way of loss of life. The Fletcher-Peto curve, which is what this is, looked at this in various countries and continents. So the top on here is men and women from the UK. So the left is men in the UK, the right is women in the UK. And you can see, starting from the age of about 50, these two graphs start separating. So what are the two lines? The top line is people who've never smoked. The bottom line is people who've smoked for at least 40 pack years. So 40 pack years of smoking, you can see the lines separate out at 70, and that's a decade lost in the way of your longevity. The same pattern is true in the US, men and women, and then in Japan and India, because there's less incidence of smoking among women, you've only men on those two Fletcher-Peto curve, but the pattern, whether it's the UK, whether it's US, whether it's Japan, whether it's India, remains exactly the same. Loss of 10 years of your life and a lot of disability-associated life years. What are the health benefits of quitting? And more importantly, when do you start perceiving the health benefits of quitting? And apparently it's very early. How early? As early as 20 minutes. So your pulse rate starts returning to normal. You're normally tachycardic if you smoke. Your baseline heart rate in an active smoker is about 10 greater as compared to a non-smoker. So within 20 minutes of quitting, the decision of quitting, your pulse rate starts returning to normal. And then you've got various time frames in which things start normalizing. So 48 hours, carbon monoxide is almost completely eliminated from the body. 6 months from quitting, lung function improves by 10%. 10 years of quitting, your risk of lung cancer falls by 50%, and so on and so forth. 15 years after quitting, your risk of heart attack falls to the same level as someone who's never smoked. So quitting helps. The help starts off within 48 hours, but the more important thing, it continues way beyond, continues to 15 years or even after, when your longevity, your quality of life, your risk of organ damage all start going southwards. That's the Fletcher-Peto curve. All of you have seen this. I won't spend a lot of time. The reason I'm putting up this slide after putting the previous one up is to show that it's never too late to quit. Again, if you can see my cursor, someone quitting at 50 has an improvement in lifespan of about a dozen years, 12 years. However, the morbidity benefit, the improvement in quality of life, the reduction of organ damage is far greater. Someone who's quit at 70 still has an increased longevity of 3 to 4 years. At 70, 3 to 4 years. Again, importantly, the quality of life improvement is significant. Hence, remember, it's never too late to quit. It is never too late for you to advise a patient of any age to quit. And quitting should be of paramount importance. The advice to quit should be of paramount importance to every patient who's a smoker. So that's a strong message from me to all of you to advise quitting. However, why is it important? Why is it difficult for the patient to do so? So anyone you advise to stop smoking, or if you're a smoker, you would realize yourself that quitting smoking is the most difficult thing people would do in their lifetime. So the hardened smoker finds it impossibly difficult to quit smoking. However, having said that, with advice from people like yourself, most adult smokers would have made a few attempts to quit, and they've made it with all seriousness. Majority of smokers fall on their face because they try and quit without any assistance. And when I say without any assistance, I mean counseling, psychological assistance, support, and drugs, to which I'll come to in a moment. Fewer than 5% of unaided quit attempts last 12 months. Look at that number. Remember that number. only 1 out of 20 people will manage to sustain quitting tobacco for more than a year, 1 in 20. Hence, aiding quitting, your role, my role in trying to get people to quit is extremely important. People spontaneously giving up is something which happens very rarely. Most smokers make 8 to 11 attempts. So in the UK, the mean is 10. 10 attempts to quit results in 1 successful quit attempt. The long-term outcome of interventions conducted at smoking cessation clinics remain poor. However, unassisted tobacco cessation is probably the poorest way of trying to give up smoking. What are the barriers? And you can see the list on there. There are a lot of this which you would relate to. So peer pressure is important. This, your friends who smoke, there's friends who laugh, you're having a drink, you're having a smoke, and you're sat with them, and they tell you to give up, smoke a cigarette, and you just light up again. So that's peer pressure. Lack of psychosocial support. I talked about this just now. It's important to seek support. It's important to seek counseling. It's important to talk to your doctor in trying to obtain psychosocial support. The attitude towards smoking cessation, the fact that people feel they're trying when they're actually not. So the attitude towards smoking cessation is important. Younger age is a deterrent to stop smoking, even though that's probably the best time where dependence, the physical dependence factor is not so great. Young people stopping smoking is difficult. You end up having a terrible disease like an ischemic heart, like an MI, for instance, or a stroke before you think of stopping smoking. Even worse, you have your lung cancer and then you think, okay, let me stop smoking now. That's probably too late in the day. Lack of community awareness and trained professionals who tell you how to go about stopping smoking. What are the factors that you might feel when you try and stop? Trained professionals to tell you that are unfortunately lacking. And poor follow-up in subsequent visits is also important. This is a slide I love and I use for all my presentations that came out in the British Medical Journal. A lovely article that came in from Chian's group, a Korean group. And this shows you the grounded theory of barriers to smoking cessation. And I want you to start off with number 5, the biggest part of the arc at the top. So number 5 is failed assisted smoking. So failed assisted smoking is when the assistance is in a language which is alien to you. People don't understand the methods that work. And when I say people don't understand, the person who's delivering the advice really does not understand the implications to it. So that's failed assisted smoking. Number 4 in that list is misconception. So people think that smoking cessation is a mind game and that suddenly stopping smoking might be harmful to health. This is something I hear even doctors say, don't stop smoking suddenly. Now, there was this study in the UK which looked at 2 different ways of stopping smoking. One was gradually cutting down on numbers till you reach 0 and then you maintained it at 0. The second attitude was what was described as cold turkey. So you stopped in one go and never smoked again. They used an interesting concept in the UK. They would have an important day, maybe the 1st of January, New Year's Day, maybe their own birthday, maybe their marriage anniversary. And they would say that I would smoke my last cigarette at 12 midnight the night before and physically throw the packet out of the window. And you know, the physical act of throwing the cigarettes out gives you the passion, gives you the motivation, gives you the positivity to stop smoking forever. Cold turkey works much better than cutting down. When you start cutting down, after a little while, you might have a quarrel with your wife, your boyfriend, girlfriend, you might have a stressful day at work, and you restart again in large numbers. So the misconception about how to stop smoking is the second barrier that this paper talks about. The third is social and cultural. So social and cultural is like accepting cigarettes. You know, one of the things people feel, especially, I mean, you are all youngsters in the audience today, you would know offering a cigarette, lighting up from someone else's cigarette is thought to be something which is very social. It helps develop bonding. Believe me, there's better ways to bond rather than lighting up from someone else's fag. Nicotine addiction. So physical symptoms of withdrawal or feeling the need to ask for a cigarette from other smokers. So people say, I have stopped buying cigarettes, but you see them asking for cigarettes from others, lighting up from others, having a bidi from others. So that's nicotine addiction, the physical dependence, where people cannot help themselves when they see other people smoking. And the last, the lifestyle and social factors, where again, similar lines, inability to resist temptation in presence of smokers, easy access to cigarette, you've got your maid, you've got your home help who goes and buys the cigarettes for you, and this impairs your self-control and tends to get you out of your tendency for boredom. So failed assisted smoking, misconception, social and cultural factors, nicotine addiction and physical dependence, and lifestyle and social factors are the 5 themes which form the grounded theory of barriers to smoking cessation. So I'll come to drug management for the last 10 minutes, but that's the summary. The fact that smoked tobacco is one of the most addictive drugs that mankind has ever discovered. Smoking is associated with a high cost. We have said that across countries and continents, it results in a loss of a decade in life expectancy. Quitting smoking is difficult. There's major barriers for long-term tobacco, including peer pressure, lack of psychosocial support, lack of community awareness and trained professionals, and poor follow-up on subsequent visits. So let me quickly do quit methods now, the drugs, which I'm sure all of you know about. But before drugs, it's the psychosocial bit, the psychological support that we spoke about. And here you would appreciate, we keep repeating this. However, it's very, very important. So the first is ask. So every time a patient comes to you, you identify that person as being a tobacco smoker or a tobacco user. You implement that every patient at every clinic visit should be asked how much they're smoking, whether they've cut down, whether they've managed to stop, and this should be documented in the prescription or in the source document. The second is advice, which is easy. Ask them to quit smoking. And then it's the assessment. So not everyone is ready to quit. So when you're prescribing medications, drugs to help in stopping smoking, make sure that there's a willingness on the part of the patient to stop. Otherwise, you have people who get addicted or dependent both to your nicotine replacement therapy and to the nicotine itself. And that's a dual challenge. So taking people off the nicotine gums, taking them off the lozenges is a dual challenge. They smoke and they take the nicotine replacement too, which makes it a double whammy in the way of the losses, the health hazards that these patients face. So that's assess. The fourth is assist. Aid the quitting process, which mainly talks about counseling. It also talks about the treatment that I'm going to describe in a moment. So that's assist. And then arrange, which is to schedule a follow-up. That's very important. The follow-up can now be a virtual follow-up, akin to what we are doing on a virtual platform today. It could be in person. And normally for counseling, the physical contact counseling helps more than the virtual counseling, but the virtual counseling is much better than nothing. What are the other ways of quitting? So the 5 ways we talked about, the other is talking about lung age. And I won't go into a lot of detail. I can give you these slides for you to read later. But lung age is a tool where you look at a patient's FEV1 and tell them how much their lung age is greater than what it should be because they've used tobacco or smoked. So for me, I'm 52. Suppose my lung age is also supposed to be 52. Now, the FEV1 tells you, the drop in FEV1 tells you that my lung age is 80. The machine tells you that. So it's a shock to my system when I see that someone who is 52 has a lung age of 80. And that shock results in quitting of smoking. So that's the theory. And this shows you the results. So this study, which had 2 different, one a control group where you had placebo, where you had the normal ways of asking to quit, and the other showing lung age and telling smokers their lung age based on spirometry, impaired the likelihood of quitting. Hence, lung age seems to be something which is important. Now coming to pharmacotherapy. So pharmacotherapy is divided into two broad groups: nicotine replacement therapy and non-nicotine replacement therapy or pharmacotherapy. So in non-nicotine, you have two drugs which we'll talk about. One is bupropion and the other is varenicline. So varenicline, bupropion, nortriptyline have all been shown to increase long-term quit rates, but it should not be as a replacement to supportive interventions like counseling. So the counseling is a must. You're telling the patient to quit is an absolute must. You trying to find out whether they intend to quit or not is something that is a must. The pharmacotherapy, be it nicotine replacement or non-nicotine replacement, is an option depending on what patient. So what are the different forms of nicotine replacement therapy? There are 4 different forms in which the drugs are available at the moment. One is the gum, the other is the patch, the third is the inhaler, and the fourth, which is not written on there, is the lozenges. So gum, patch, inhaler, and lozenges. The gum, while being effective in light smokers, remember the definition of light smokers. So while being effective in light smokers, also has some GI side effects. So it causes dyspepsia, it causes hiccups, it causes mandibular pain from all the chewing that these people do. Patches also have some amount of side effects: dizziness, nausea, sleep disturbance, a rash when the patch is applied. However, in my clinical practice, I find the patch very useful, especially because dependence on a patch is not something that we see. That happens with the gum or with the lozenge. The nicotine inhalers also have adverse effect. The effect of inhalation is nasal itch, irritation, rhinorrhea, sneezing, and coughing. Contraindication to nicotine replacement therapy is you shouldn't use it, or you cannot use it within 2 weeks of a cardiovascular event. Very, very important. Continuous chewing of nicotine gum produces secretions that are swallowed rather than absorbed, resulting in absorption and potentially causing nausea. And acid beverages like coffee, juice, soft drinks interfere with the absorption of nicotine. So just to summarize what I have said, the gum is not user-friendly and it delivers 25% less nicotine compared to lozenges. The patch is slow to act. Skin reactions like a dull pain when it's applied or itching when it's applied is important, and sleep disturbance if used at night is important. The spray or the inhaler causes some burning of the throat, it causes nasal discharge, and has poor compliance. So there's a lot of push for using the lozenges, which I'll show you in a moment. That's the nicotine lozenges, and the advantage are thought to be the flexibility of its use, quick absorption, as effective as other therapy if used as per advice of the doctor. It doubles the likelihood of successful quitting and delivers more nicotine as it dissolves completely. The downside of nicotine lozenges is the increased absorption. So you have greater nicotine, the chances of dependence are greater on the lozenges. And I know of people who've had to apply patches to get off lozenges. They've got off smoking, become dependent on lozenges, and then you need a patch to come off the nicotine lozenges. And that's important to remember. This is a study from about 15 years ago, which looked at the dosing of lozenges, and that's the reason I put this up. This is something which is easily available in this country. It's cheap, so something that you should know. So when a person says that they want to quit, week 1 to 6 is 1 lozenge orally every 1 to 2 hours with the maximum of 16 lozenges per day. Week 7 to 9, 8 lozenges per day or 1 every 2 to 4 hours. And then week 10 to 12, 4 lozenges or 1 every 4 to 8 hours. And this is a comparison between the gum and the lozenge, which shows that the lozenge scores over the gum in the fact that there's more nicotine available in these individuals. The next, I found this on the web. The next bit that I want to speak about is e-cigarettes. E-cigarettes were came into being and are still used in some parts of the world as a mode, a modality to try and quit smoking. However, its use remains very controversial, and that's more because substances like tetrahydrocannabinol or cannabinoid oils, which are used as flavoring substance or additive, which are added to the nicotine, cause a lot of lung damage. So acute lung injury, eosinophilic pneumonia, alveolar hemorrhage, respiratory bronchiolitis, which is sometimes called popcorn lung, are all factors which are caused more by these flavoring agents in e-cigarettes rather than by the tobacco smoke. So that's important. E-cigarettes are banned in our country and in a lot of countries throughout the world because of the damage that they do to the lung. Bupropion was once prescribed willy-nilly for smoking cessation. However, there's a lot of problems with bupropion, and its use for smoking cessation has now reduced drastically. Most common side effect is dry mouth and insomnia. Risk of seizures is thought to be 1 in 1,000, but the trials which have looked at bupropion excluded patients who had even risks of seizures. Hence, the use of bupropion comes under question because of the side effects, because of its potential of reducing the seizure threshold, and hence it's no longer in vogue. Varenicline is the drug which is most often used even today. It's an effective agent. It's an acetylcholine, acts at the acetylcholine receptor. You can see the alpha-4 beta-2 receptor, and it helps by modulating dopamine release in the nucleus accumbens. The fact that it's a partial agonist, so it doesn't work on the receptor as much as nicotine does, but to a lesser extent in a similar way, helps in reducing nicotine dependence. So it can do two things in working. One is it stimulates the dopamine release to reduce craving and of withdrawal. And at the same time, through its partial antagonistic properties, it blocks the binding and results in reinforcing effect of nicotine derived from smoking. So you can see there are two effects. One is the agonistic effect, which is through dopamine stimulation, and the other is the antagonistic effect, which is by blocking the ability to bind, for the nicotine to bind to the receptor. So this is a lovely slide that I want you to remember, maybe reproduce in your answers. This is looking at the full agonistic activity of nicotine at the receptor and the partial agonistic activity of the drug at the same receptor, which reduces the potency of nicotine by less than 50% and hence relieves craving and withdrawal. And this is the antagonistic effect, where it binds to the receptor and blocks the nicotine from binding to the receptor site. So something that you need to remember about Varenicline. And hence, Varenicline significantly reduces quit rates. You can see the numbers on there, and you can see a p-value which is far better as compared to both bupropion and the nicotine replacement patch. So more efficacious and a safer agent. So Varenicline increases abstinence in COPD smokers by about 60% in a study. Patients with COPD as well as non-smoking COPD had similar abstinence rates, but even a more severe addiction. Varenicline seems to work as compared to nicotine replacement therapy. And motivation is the sole predictor for long-term abstinence. This is a Cochrane meta-analysis which looked at all the different drugs which have been tried in tobacco smoking cessation, and it shows that Varenicline in single use, as in no combination, but just Varenicline alone, is better than any other single agent in stopping smoking. And this is the complicated treatment algorithm for COPD smokers. Again, I'll leave this with Dr. Shamajhdar for you to see, but it tells you how to use NRT in your COPD smokers, and an algorithm which maybe you could use in your day-to-day clinical practice. And this is a prescription. This is a prescription which will remind you to talk about cigarette smoking and its cessation at every visit. The Varenicline tartrate is just an example. You can put in some form of nicotine replacement therapy here, but if you create a box that you've actually ticked about smoking cessation, it'll help you to remember that smoking cessation advice is something that's important to give in all your patients. So what we've discussed today is that smoking is the worst of evils, even compared to things like cannabis, heroin, opium, etc. It's not just about COPD or lung cancer, it's multi-morbidity. Every organ in the body can get affected by the effect of cigarette smoking. The fact that there's no replacement for counseling and psychological support, the drugs that you have, the pharmacotherapy you have is an add-on, an essential add-on, but an add-on to counseling, etc. Pharmacotherapy seems to be of greater help. So Varenicline seems to be of greater help as compared to NRT. And important, whenever you see someone who smokes, never miss a chance to ask them to stop. It's not just the patient who gets benefited, it's also their family members, the children, the friends who also are benefited because you prevent passive smoking in these individuals. Thank you so much for listening. And I think I've taken up a bit more of time than what I had promised.
Thank you very much, sir. It is always great to hear you, even if it crossed the time. So thank you once again, sir. So now may I request our students, if you can ask sir questions, you can unmute yourself and directly ask sir questions. So there is one question already asked by Dr. Anisha Matthew. With your permission, sir, may I read out that, sir? So he had asked, what is the dose of bupropion and Varenicline that is to be given? So I think sir has already discussed in the slide in his slides about the dosing.
Sorry, Shambhu, I think my internet connection is a little unstable just now. I lost you for a moment. Can you hear me?
Yes, sir. Now we can hear you, sir.
Okay. So the dose of bupropion and Varenicline would be, so Varenicline and bupropion both come as packs. It's like the oral contraceptive pill. So you need to just peel off the drugs and the patient takes the drugs. It tells you which days, how many days you need to take it for. I would advise not to take or prescribe bupropion. It's mainly Varenicline, and the Varenicline dose is written on the pack, starts off as 0.5 milligram and goes up to 4 milligram, but the doses are written in the packet itself, so you don't need to memorize them by heart.
Okay. Thank you, sir. Thank you. So again, Dr. Jitendra Singh had mentioned that great lecture, sir. Enjoyed thoroughly. I have to leave. Okay, you have to leave. So sure, Dr. Jitendra, you can leave. So any question to sir?
So,
yeah, please unmute yourself. You can open your video and ask sir question. Yeah.
wanted to ask what
I can hear
molecule
you. Please go on.
Varenicline, sir, it was told that it has some impurities and nitroso impurities, which has an increased risk of cancer. So I just wanted to know ki in the practice it is getting affected, or I was having a misconception that bupropion is the line of treatment till now, but after you're listening to your presentation, it seems that Varenicline is the first choice for the physician. So just want a clarity between the two molecules.
So bupropion, as you know, Priyanka, is an antidepressant.
Okay.
It's used by the psychiatrist, but even they use it sparingly now because it reduces seizure threshold in this population of patients. So the risk of seizures is great. Varenicline, there were isolated reports, much like the COVID vaccine from Pfizer, that it increases the risk of cancers. But in trials, the risk is no more than 1 in a lakh, which is probably your incidence of cancers in the general population. So I think whenever you prescribe a drug, you need to find out whether the risk is greater than the risk of that disease process in the general population who don't have any risk factors. And with Varenicline, with the vaccine, for instance, it's no different as compared to what you have in the general population. The data shows that efficacy of Varenicline in smoking cessation is significantly greater as compared to that of bupropion in the meta-analysis that I quoted a little while ago.
Okay. Sir, what about bupropion's SR formulation, sir?
The sustained release, I don't think the sustained release formulation has actually been trialed separately. I actually don't know which formulation of bupropion was actually used in the trial that I spoke about. I'll have a look and I'll let Dr. Shamajdar know and he'll relay the information to you. But I think the reduction of seizure threshold would be similar in both the sustained release and in the shorter acting version. I don't think that changes across versions of the drug.
Sure, sir. Thank you so much. My second question would be, sir, in the alcohol withdrawals or in any other addiction, as we have anti-craving agents also, any particular anti-craving agents for nicotine addiction, sir?
So that all of these are anti-craving agents, as you put it, Priyanka. So be it the nicotine replacement therapy or be it these drugs, all of them have, like I said, a partial agonistic and an antagonistic action. So the antagonistic action is what looks after the craving of the drug. The nicotine replacement therapy, in whichever form you take it, is only for the physical dependence and to reduce the craving for the drug. So that's why you're giving them in gradually reducing doses, because as time elapses, you understand that the craving becomes less and less, and hence the requirement for nicotine replacement becomes lesser.
Sure, sir. Sir, one more question in relevance with the nicotine, sir. Sir, when in your actual practice, clinical practice, what do you think, sir, in between the nicotine transdermal patches, lozenges, and gums, from the three, which would be the preferred choice for the patient, sir, for you?
So Priyanka, I use the patch the most. I'll be honest with you. I use the patch the most simply because I have had a lot of experience in seeing that people actually become dependent on the lozenge and the gum. They might actually, some people would take both the lozenge and the cigarette. Some would take both the gum and the cigarette. And then I am left with the dual responsibility of trying to get them off both agents. Some people stop smoking, but they keep taking the lozenges because that feels very nice. And then there's a dependent on the lozenge. Such factors don't come in when you use the patch. The problem with the patch in our country is the local skin reaction and the fact that ours is a tropical country where there's a lot of sweating. So the patch often peels off by itself. However, I am a fan of the patch. And if I have to use an oral agent, I would use the lozenge.
Okay. Thank you so much, sir, for all the inputs which you have given. And thank you so much for a wonderful presentation, sir.
Thank you for listening, Priyanka.
Good afternoon, sir.
Hi, Amrita.
Hi. Hello, sir. Sir, it is an honor to have a lecture from you. I'm really really lucky to learn from you. So one thing I wanted to ask regarding this, that what is the approach for a patient if is there a difference in approach for a young smoker or an old smoker who already has COPD? And how do you approach whether to go for nicotine replacement therapy, and then if that fails or if the patient is not able to come off, then start with Varenicline, and if at all, or to start with Varenicline upfront, and if at all we are using Varenicline, for how long should it be used, and when should we think of stopping it?
Amrita, great questions, lovely questions. So what is the difference between a young smoker and a aged smoker? So the young smoker has probably not smoked for a long time and has probably also not smoked many. So if you can convince them, the problem with the young smoker is the peer pressure. So their smoking is more related with their friendship, their social bonding, the fact that they're going for a drink or to a pub, where smoking is seen to be a social norm rather than an exception. That's the problem with a young smoker. And there, if you can persuade them about the risks, all the Fletcher-Paton curve, the fact about lung age, etc., comes in very useful at that age. These people are susceptible to suggestion. And if you are passionate, if you are convinced that smoking is bad for you, then you can probably transfer that confidence onto your youngster. In a youngster, I would often give them Varenicline. The reason I give them Varenicline is twofold. One, it has a lot of effect. The second, it's an expensive drug, and people, if they manage to buy the Varenicline, almost feel obliged to stop smoking because they don't have any money to buy the cigarettes after. So it's it actually helps. Even it sounds stupid, but it actually helps, because if you buy something for say 8,000 rupees, for a 3-month course. And that's the other answer, the answer to your question, Amrita. How long Varenicline? Varenicline is a 3-month course.
3 months. Okay.
So if you've invested that amount of money, you almost feel obliged to stop smoking, at least for the time being. So that's about young people. Elderly people, I would talk to them about not smoking every time, but the older they get, the only time they would normally stop smoking is when they unfortunately have had a health effect of smoking. So some people would stop smoking after they've had an MI. Some people would stop smoking when I tell them you got bad COPD and they're breathless. Some people would stop smoking after they've had a stroke, and so on and so forth. So unfortunately, it's event driven. And there I would give them more of nicotine replacement therapy, because I think them buying a Varenicline or a bupropion is going to be unlikely. And second, between nicotine replacement therapy and the non-nicotine replacement pharmacotherapy, NRT is also safer. So I would give them NRT rather than subjecting them to a Varenicline or bupropion.
Thank you so much, sir. And sir, so one more thing I wanted to ask. As in India, we have a lot of BD smokers and a lot of hookah smokers. So do these things work in hookah smoking as well? And
they would do.
Okay.
They would do. So I use the patch even in people who have oral tobacco. I mean, of course, if you smoke it, whichever way you smoke it is going to work. So in BD, in hookah, it's definitely going to work. But what I'm telling you is the other end of the spectrum, that I would use NRT even in people who are chewing tobacco, oral tobacco. I would use a patch even in them, and I do so in my clinical practice. So when these people get hospitalized, the first thing I do is to talk with them, tell them that the next time they come in, they might not come in alive. They might get killed because of the smoking. And then I ask them, do you want to quit? Most often at that time, they would say, I would want to. And I put a patch onto them. So that's a good time to start off with nicotine replacement therapy. But note, always after counseling, always after finding out the intent to stop smoking.
Okay. Thank you so much. Thank you so much.
Thank you, Amrita. I think Subrajit wants to ask a question.
Okay. Namaste, sir. Sir, I am Dr. Subrajit. I am a pediatrician. So, sir, it was a very nice lecture to hear from you.
Thank you, Subrajit. I can't hear you well. Can you speak a bit louder, please?
Sir, I am a pediatrician. So, I love the lecture from you, sir. Just want to ask you one thing from my perspective. In pediatric age group, that is adolescent age group from 11 years to 19 or 20 years, sir, sometimes we get many patients who are being addicted to tobacco, that is gutka. So, sir, how you manage the children and what is your experience regarding this? This is my first question. Second question is, sir, about maternal smoking. Maternal smoking, though it is rare, but in some places it is also, the numbers are high. And when those girls are becoming mothers, so how are you managing? Suddenly in pregnancy, are you advising some medication, or are you? What is your experience regarding this?
So, answer to the first question, Subrajit, is that unlike you, I am not a pediatrician. I am an adult physician. However, I do get youngsters sort of late adult, and I would tell them about the risks of oral cancers and also the other risk factors. These people, like I said, if you manage to spend some time with them, if you manage to scare them a little, I think getting them off the gutka or the oral tobacco is not so difficult. I use nicotine replacement therapy rather than non-nicotine replacement pharmacotherapy in these individuals. I would use nicotine gums here more than using a patch or the lozenges. I think these population of patients want the effect of chewing, and I would gradually come down on the dose of either the lozenge or the gum, whichever I choose to give to them. So that's the message about the gutka chewers, the youngsters. The one about maternal, I think smoking is a greater challenge now in women as compared to what it is in men. If you look at data in our country, the number of people smoking, the number of men smoking in India have plateaued off. It's not started coming down like it has in China or some other countries, the Western world, but it's plateaued off. In India, the number of women smokers are going up about 3 times every year. And you heard me right, 3 times every year, is the increase in number of women smokers, especially in urban India. So I think pregnancy is a good time to actually get them off smoking. You know, if you talk to them that if you smoke, you're not just harming yourself, you're harming the baby. It's like having an MI for a man. You know, the man loves himself the most. The lady probably loves the child more than they love themselves. So if you tell them that you're harming the kid more than you're harming yourself, or as much as you're harming yourself, most of them would actually stop smoking at that point of time. Women, the peer pressure factor is less. So your success with good counseling in getting them off smoking is going to be greater as compared to what it is in the man. So I think it's actually more rewarding counseling a woman because your success rates with counseling is going to be greater with the woman as compared to what it is going to be for the man.
Yes, sir. Yes, sir. Thank you very much, sir. Namaste.
Thank you.
Thank you.
Thank you, sir. Thank you. So, Dr. Nishchal from Nepal, you want to ask some question?
So Dr. Nishchal has said, while advising for smoking cessation, most of the parents of asthmatic children say that they smoke outside the home, not in front of their children. How should we counsel them? So I think, so it's about both, Nishchal. So thank you for your question, and thank you from logging in from Nepal. Shows how popular Shambhu's program is. So well done to everyone. So I think the first factor is that you have to be convinced that you're harming yourself. Going outside and smoking might be something which is feasible during the daytime. It is often not feasible at night. So I think, A, they might smoke most times outside the house. A few times they would smoke within the house, which would still cause passive smoking. But you cause yourself as much harm by smoking within or without outside the house. So I think you need to be convinced that you're harming yourself. And if you harm yourself and you have one of the health hazards from smoking, you're not going to be able to bring up your kid the way you would do if you were completely disease-free. So I think there's ways of approaching it. And I think it's your passion, Nishchal, your conviction that smoking is bad for you, which needs to get transferred onto the patient. And I have seen that give me the most success in counseling people against smoking.
Thank you, sir.
Thank you, Nishchal.
Thank you, sir. So we need to end up today. So we are really hopeful, sir, to meet you physically with all our students
Sure.
in School of Tropical Medicine in our point of contact session 2. So we are keen to learn from you about the asthma phenotypes there. So thank you once again, sir.
Sure. Looking forward to that too, Shambhu. Thank you for inviting me and being kind. Thank you so much.
Thank you. Thank you. So thank you all. We are ending up today's meeting.
Thank you so much, sir.
Thank you, sir.